everyone. I'm Dr. Noor Al-Nebari. Welcome back to our show. Hope you all had a nice weekend. This is Dr. ANOUD.
Hi everyone, I'm Dr. ANOUD JUWAIHEL. Thanks for watching us today on the KDB2 Healthy Life channels. Today we'll be proudly, we're going to meet one of the interesting doctors here. But before that, we're going to start with showing our contact information on the screen right now, please. Today I have a couple of interesting, actually, medical news, Dr. Noor, and I got the latest medical news from Medscapes. And the first one we have on the screen right now is talking about the male pattern baldness linked with coronary heart disease. So there is a new study suggests that early, men with actually hair loss on their vertex or then on their scalp actually are more prone to have coronary heart disease.
Which is very, very bad news to hairless people.
Exactly. And especially it goes for people who lose their hairs at early 30s or early 40s. This is actually could be a risk factor for coronary heart disease. So my actually advice for men who lose their hairs or have a very thin hairline on their scalp is to have to modify the other risk factor for coronary heart disease. So they have to look for their cholesterol, they have to look for their sugar status, they have to look for their weight also.
Yeah, but how common is it in bald men? Is it really that common?
I think
because it's kind of scary. I think everybody's now freaked out.
I have another freaking out news now.
Okay.
And if you're gonna see also, there is also a news for also men who have baldness, and it suggests that early baldness may be a risk factor for also prostate cancers. So it is also a new risk factor. So men actually with the hair loss, they have to be more cautious about the risk of prostate cancers. And what I mean about that is they have to have certain screenings regularly to prevent as a prevention process to prevent themselves from having prostate cancers. So there's another issues about the lifestyle intervention for pre-diabetes is successful. This is an interesting article that I read also from Medscapes, and this gives a hope for people who have high risk of having diabetes, or as we call them, pre-diabetic. So if they have if they go on to have a certain lifestyle modifications, they will definitely reduce their risk of having diabetes later on.
That's really good. And so everybody should, have early, they just have to take care of their health, and they should exercise and eat really healthy food in order to prevent this from happening. And I think it's not just for diabetes, it's for a lot of medical problems.
So when I mean about lifestyle interventions, exercise would be number one. And modifying, food, having good habits about, what to take or not to take. Having healthy food would be really of benefit for these people. And a regular visit with their doctor to check about the other status as well to prevent coronary heart disease as well. So, Dr. Noor, if we're going to move on to the conferences, what do you have?
We have a conference. And it's the regional insights and a call for action in patients with COPD. And here is the report about this conference.
John Hurst. I'm a doctor working in London in the UK. I work for University College London, so as well as being a doctor, I also do some research. And what I'm here to do today is to talk about a really important lung condition that has the name chronic obstructive pulmonary disease, or COPD. So I'm here to tell everybody about COPD. Most people who get COPD, it is in some way related to smoking or to pollution. So the most important treatment for anybody who has COPD is to stop smoking, because that's the most important thing to stop them from getting worse in the future. If we're getting past smoking, then we can think about treatments in two different ways. We can think about treatment that is with medications and treatment that's not with medication. So let's talk about not medications first, okay? So exercise, that would be really important, keeping the lungs as fit as possible, and education about the disease so that the person can manage it effectively themselves. We might also think about vaccination, so vaccination against influenza would be important. So we have some treatments around drugs, and then also we have drug treatments. And the best drug treatments for COPD usually come in inhalers. And inhalers come in lots of different shapes and sizes with lots of different drugs, but they're really there to do two different jobs. Some of them are there to open up the air tubes, they relax the air tubes so that the air can get in and out more easily, and some of the other ones are there are anti-inflammatory to try and affect the COPD itself.
That was the report of the conference, and it covered a lot of important issues in, about COPD, and it's, the major take-home message for our audience is just to stop smoking, just to prevent this from happening.
I think this is very important lectures for all, the general practitioner to listen to give a lot of advices for their patients, especially if they are heavy smokers, because quitting smoking would be of great value for all the patients.
Yeah.
And now we move on to our interesting part of our show. We're gonna meet, or we're gonna interview one of our best endocrinologist consultants, Dr. Nadia Ali. Hi, doctor.
Hi, hello.
I'm so glad actually to have.
I'm so grateful you invited me for your show. Thank you very much.
Thanks for accepting our invitations, Dr.
Most welcome.
Nadia. Dr. Nadia, today our talk we're going to be focusing a lot about the osteoporosis and vitamin D deficiency, which has a really a great impact for all our patients, and it's so important to us.
Absolutely true.
Dr. Nadia, can you tell us exactly what is osteoporosis and why it is so important to let all the people know about it?
For simple people, I'll just say osteoporosis is a weak bone that is very fragile and liable to fracture.
Yes.
Why it is so weak? Because the density of this bone is much less than the normal bone. If you would focus in this picture, which compares a normal bone to an osteoporotic bone, you would certainly appreciate that the normal bone is more thickened, and there are a lot of bridges in between the bone cells.
Can we see the pictures, please, if you don't mind? Yes, so you said the pictures.
The normal one, is it showing on the screen?
Yes.
The normal bone is really thickened and a lot of bridges which give us the strength.
Yeah.
So it can resist any fracture or any trauma. Whereas as the osteoporotic bone will be very thin and less of a bridges between the bone, so that it is weak, and with the minimal trauma it's liable to have fracture. Okay. So by definition it's the loss of the architecture of the bone thinning of the bone and rendering it very liable to fracture.
Exactly.
And how common is osteoporosis in Kuwait?
It's a very common disease, I would say. And it's estimated internationally that after the age of 50, 1 in every 3 women will have osteoporosis.
Wow.
And 1 in 2 women will have a fracture in her lifetime. In men, 1 in every 5 men, so it's around 20% in men over the age of 50.
So they're more protected than us?
Well, they already have baldness and coronary artery disease, so from the bone point of view, I think they are having privilege.
Yeah.
So it is commoner in women rather than men, and that is probably due to that women have a rapid decline in their sex hormones, which is that is estrogen during menopause. Whereas men, they go into andropause, but that's very gradual, and they might reach up to the age of 70 or so with minimal change in their sex hormone.
Yeah. How can we compare the prevalence of osteoporosis in Kuwait and the other world? Like, are we the same?
Well, let's look at it from 2 angles. One is the bone mineral density. Are our population having the same bone mineral density like the Europeans or the Americans? In fact, the studies from Kuwait has shown that we do have comparable levels of bone mineral density. So our bones are not less. And in fact, that contradicts the other results from neighborhood. So from Saudi Arabia, from Qatar, Morocco, Lebanon, all these countries has shown their bone mineral density of their females is around 8% less than the European and the Americans, but the studies from Kuwait has failed to show this.
Okay.
And that will reflect on the prevalence of postmenopausal, that is the ladies after the menopause, osteoporosis. Whereas it's reported in Saudi Arabia and Morocco to be 40% in women after the menopause. In Lebanon and in Kuwait, it's only around 20%.
All right.
So,
and I believe probably studies in Kuwait have included younger females. That's why the prevalence is low.
Right.
I guess any study to look into osteoporosis should only include women 50 and above.
All right.
But does it occur in women who before menopause?
Yes, it will. If they have some medical condition or they're on drugs or other secondary causes we call.
Yeah.
But the main cause will be either aging for men or menopause for women. That's the main categories of the osteoporosis.
Okay.
And secondary causes that we need to know the risk factors then.
Yeah. So what makes people more prone to have osteoporosis with regard to a secondary, risk factors?
Okay, I mean the 2 major things we said, the age. So above the age of 60, they will have more prevalence of osteoporosis. Females, like we said, are more prone. Then the secondary cause are related to the family history. If you are coming or descending from a family with a strong family history of osteoporosis, your chances are high to have osteoporosis. And we particularly look to the history of if mother or father either had a hip fracture, then they put them in really increased risk of osteoporosis. Other causes are related to low sex hormones before the age of menopause. Like many women will have problems or with high prolactin or something, and men as well, they can have the same problem with low sex hormones. So those patients are high risk of osteoporosis at a younger age. And of course, conditions that prevent the body from absorbing calcium and vitamin D and other important nutrients, like any malabsorptive condition, like inflammatory bowel disease and celiac disease, which I believe is underdiagnosed, and we have a lot of subclinical cases around.
Exactly.
And not only this, but we are creating a lot of population with malabsorption with the bariatric or the metabolic surgeries. So all those who had metabolic surgeries related to malabsorptive state, like the bypass surgery, are at higher risk. And also those who have a sleeve are at slightly higher risk because of their poor nutritional status post-operatively. So other things will be related to drugs, like those, particularly those taking corticosteroids.
So
and you know, corticosteroids is a very common drug and is prescribed for so many conditions. Bronchial asthma, for example, lot of nephrology or renal diseases, lot of rheumatological diseases. So I would consider that's the first enemy or the biggest enemy to the bones.
Is there any certain dosing for the steroid use that could put
well,
the
even with minimal inhalation dose, there is some changes in the bone. But they had set the level of 5 milligram and above daily for 3 months at the risk with osteoporosis. Yes. And of course, there are so many other risk factors. If you want me to continue, a lot of drugs. And one of the mostly prescribed drug, commonly prescribed for no reason sometimes, are what we call the PPI, the drugs that reduce the acidity of the stomach.
Which is extremely commonly used.
For no reason. And when I start reviewing all my patients, I could discontinue it for almost half of them without any adverse effect on the patients.
And why is that? How does it really
Because you need the gastric acidity for proper absorption of the calcium.
All right.
And if you render the stomach chlorhydric, no acid in the stomach, then that will impair the gastric and preparation for the calcium for absorption.
All right, okay.
Okay, and tell us about like how do women usually present with this? Like do they usually come and complain of something in particular?
Well, actually osteoporosis is called the silent disease or the silent thief because it steals your bone, and the only time you will know that you have osteoporosis is the time where you have a fracture. And at that time it's too late, probably.
Too late,
yeah, that's what we want to prevent. We want to prevent fractures. So what would be the best way? They will never come complaining of bone pains. And if they come complaining of bone pains, you have to look into other things like vitamin D deficiency or other problems in the bone, but not osteoporosis. So nobody will come complaining of pain unless they have fracture. Probably most of the cases I do see that they have developed some alertness or some information about the osteoporosis and they want to predict if they have osteoporosis. And many come seeking to do the test for osteoporosis, the DEXA or the bone densitometry. In fact, there are rules for doing this bone densitometry, and we cannot do it for everybody because it's not cost effective. So only certain types of people will do it, and we particularly would recommend that for people above the age of 60, women or men, people who have already had what we call fragility fracture, which is fracture with a minimal trauma. Somebody slipping in the bathroom and fracturing, somebody falling from their own height. If they have fracture, then they are probably at risk of osteoporosis. Or if they have any of the secondary causes we mentioned before. Particularly the steroids, we are very concerned because they do have rapid loss of their bone density with steroids. Patients who have low sex hormones, those ladies who have the menopause earlier than the age of 45 are also at very high risk. So we pick up these cases, or somebody who have their parents either had a hip fracture. So these what we call major risk factors. So anybody with any of these major risk factors, we do consider them for the test.
All right.
Minor risk factors are so many diseases in fact, many drugs besides the ones I mentioned like steroid and BBI. There are a lot of drugs that causes and many lifestyle habits that are really bad to the bones, like excess caffeine intake, smoking, alcohol consumption. Also, I would pass a message for those who keep themselves underweight, because any weight below 57 is considered a risk factor for osteoporosis.
Even if they are not anorexic?
Even if they are not anorexic. I mean, because bone needs muscles and needs strength, so it needs heavy weight to have it. I'm not encouraging obesity by any means, but I mean, at least keep a weight above 57 kilograms.
But also obese women have, it is a risk factor.
Obese,
as well.
No, they used to say that they are protected against osteoporosis, but now there is a recent research linking osteoporosis to obesity. It's not really quite clear, but I think underweight is definitely a risk factor. And let me not forget diseases like diabetes. So diabetic patients, particularly the type 1, those who need insulin and they are diagnosed at younger age, are really at high risk of osteoporosis.
So it's considered as a major risk?
No, it's a minor.
It's a minor risk.
Well, in fact, because there are too many risk factors, what we did, we have this National Committee for Prevention of Osteoporosis, and we gathered all this risk factor. And we would like all doctors in Kuwait to be aware of this. And we have set a guidelines. Let me show you, for example.
It would be very nice to show this guideline.
If you
on
can
the
show
screen.
them.
Yes, please.
Can they see it like this? Anyway, it's straightforward. So we list all the major and the minor risk factors.
Yeah, that's brilliant.
Yeah, and all the doctor needs to do is just to check if the patient has 1 major or 2 minor risk factors.
And that would be less than 60 years, is it? Or 50
no,
years?
More than 60 years.
Okay.
So if they have
it really makes things easier.
So it's for doctors to know, so if they can keep it in their clinics and they check for all the patients. I really don't know if it's showing or not. So it's easy for doctors to realize if their patients are having major, this is the dark one, or 2 of the minors, then they can request to check for the osteoporosis.
That's very nice. I was wondering, would frequent pregnancies and breastfeeding will put the women at high risk of
Yes,
osteoporosis?
it is considered a risk factor for osteoporosis.
Okay, that's great. Okay, so let's talk now more about the diagnosis of osteoporosis. What do you have like in
well, I believe the gold standard is the DEXA machine, the BMD test by the DEXA machine.
What is it exactly?
It's and you cannot tell a patient is hypertensive without checking the blood pressure by this.
Exactly.
It's the same for this. This machine is really simple. It has some X-ray, but very minimal. So patients should not be annoyed by any radiation from. They just keep the patient in the bed in certain positions, and they check 2 or 3 sites: the back, the vertebral spine, the lumbar spine, that is the spine, or the hip, and sometimes we ask for also the wrist.
Can we have a report on that, and we can talk about it, if you don't mind? Is there? Can you show the report of the DEXA scans right now, please? Can we have the report on the DEXA scan? Yeah, please. Yes.
Machine, and you'll see how they place the patient on the bed. Even the patient has to be dressed, yani we don't have to undress your patient. So you know this arm, you do see it, it will scan the back of the patient, and if the patient's bone is dense enough, little radiation will pass through. So that's really connected down with a software that will calculate how much of the radiation has passed. The more radiation passes, the more osteoporotic the bone is. So this is how they see. And then they would calculate how much this bone density is different. You see the green, yellow, and red. So if it is within the normal, it would be green. It's deviated or less by certain amount, it will be yellow. And yellow, we don't call it osteoporosis, we call it osteopenia. That is a less of a bone mineral density. The red is the osteoporosis, is when the patient is low beyond the normal ranges for the lumbar, yes, in the back spine.
And also, do you consider
the hip? And in certain conditions, not all of them, we also check the radius or the wrist.
All right, the wrist.
So that you can see also that the bones is.
So this is the pictures of a normal and
a normal and non-osteoporotic.
Okay.
In fact, this test I need also to mention something important. It's not a test that we need to do every year or every month or so. Because I see patients coming with a lot of DEXA scans. Even though it's not dangerous from the radiation point of view, but it is meaningless if you do it repeatedly.
So what do you
recommend? At least, I mean, we recommend at least 2 years between each test. The changes in the bone need some time to show up in this bone mineral density. So and even lately, they are considering 3 years between the tests.
All right.
To show any changes.
So this is basically non-invasive test?
I would consider non-invasive, yes. And really simple, comfortable patient. Even the positioning of the patient is
really comfortable. And how long does it take?
Few minutes, I would say.
Just a few minutes.
Yeah. Is there any other tests you would look for besides
Well, I would say that is the gold standard, but
yeah.
also other tests are indicated because we want to look for secondary causes. And that would include the normal blood counts, the sedimentation rate, some biochemical tests like the calcium. We want to see that the patient does not have a kidney problem or liver problems. We also need to check some hormones like the thyroid and the parathyroid hormone, which is a hormone that causes osteoporosis. And very important, we have to check the vitamin D stores.
Very good.
We always, sorry, but I add one thing. We always like to look into the urine if it has excess calcium in it. Many people do bore calcium in their urine, and that makes them in high risk for osteoporosis.
And how do you manage osteoporosis? Like what do you advise the patient?
Well, you have always to start with non-pharmacological.
Exactly.
So first of all, review the patient history. See if there are any offending causes, like a drug that you can stop, like excess caffeine intake, alcohol intake, underweight, low calcium intake is very important. So you have to really look into the dietary history of the patient. So that's mainly things you can change, the lifestyle modification, the dietary modification. Very important, you have to give advice regarding the safety in their environment. So, you know, old ladies sometimes when they go in the middle of the night to the bathroom, if it's really very dark, they have the chance to fall and to fracture. So always ask them to keep a little light so that to guide them in the way. Not in the, or the bathroom has to have the carpet so that they don't slip in. So minor things that can happen but can cause a fall. And there are also sometimes some causes that makes the patient more prone to falling, like hearing, eye problems, etc. If it's correctable, just advise the patient to correct them, because reducing the fall will reduce the fracture. Okay. So that's the non-pharmacological part.
Exactly, and we'll be back after the intermission.
Center at Dasman Diabetes Institute. Just want to talk to you about the benefits of exercise in the diabetic patients. So we do have patients who actually, what we call them at risk of having diabetes. Those patients are either overweight or obese, or actually they have a strong family history of diabetes. Those patients, or both, those patients can be at high risk of developing diabetes, and we actually can give them a very comprehensive and individualized exercise prescription to prevent the development of diabetes. And then we also see patients with diabetes, established to have diabetes, and we try to help them to control their diabetes or their sugar level much better, as well as prevent complications. We also see patients with specific complications of diabetes, most notably as the cardiovascular or heart diseases. Those patients, we pay an extra attention to them, and we give them a special exercise program to control their disease as well as prevent any progression of their complications. Patients get their blood pressure checked every time they come in on daily basis, and they also get their sugar level monitored during their exercise. They also get a chance to do what we call body composition analysis. In this test, we can tell the patients about also the composition or the percentage of fat versus muscles in their body, and we can also target this to improve the outcome of their exercise. Patients had also the opportunity to participate into either aerobic resistance or aqua exercises, they are monitored and supervised by our specialized staff who are actually very comfortable with supervising them, and they see them on regular basis and individually have a look at their heart rate every time that they exercise to monitor the progress. Again, I want to remind everyone that exercise is not only a leisure activity. Exercise is a medicine for diabetes and also therapy for diabetes, improving overall outcomes of the disease. Have a good evening.
Okay, we'll come back again. We've already talked with Dr. Nadia about the primary preventions with regard to osteoporosis. We mentioned already the lifestyle changes and the nutrition's point of view. But Dr. Nadia, can you just tell us a little bit more about the certain exercise that the woman can do?
I mean, exercise is really important because it strengthens the muscles, and once you strengthen the muscle, you are putting load on the bone, so that will ultimately strengthen the bone. Not only this, but also help the patient to maintain a good position, so that will reduce the risk of falling. Kinds of exercise that we always advise the patient, anything that puts weight bearing on the bones, such as walking, jogging. Swimming is not included in this list, but not that we are discouraging the patient from swimming. It's important for other aspects, the joints, etc., but not for the bones actually. In fact, what I find interesting are old ladies, they like dancing. And I ask them to dance Samri and every day half an hour.
Which is so much fun to do.
Yeah, it's an interesting way of treatment. So this is it's really good because they put pressure on the bones, etc., and would strengthen the bone. And they can enjoy a half an hour every day of dancing Samri, for example.
To go for the wedding then.
And what else we missed to say about?
I would like to mention about the hip protectors.
Many patients, they have the tendency to fall, and we really cannot find a reason to reduce this tendency of falling. So there is something called hip protector. It's like a corset that the lady wears, and it has some pads around the neck of the femur, around both sides of the hip. So even if she falls, that helps like a cushion to her,
to protect her femurs.
Yeah, for her hip, and will prevent fracture. So if we have no other chances of improving the risk of falling, that we can use as a protector.
I think protecting the hip is very important for all women because the rate of mortality will be very high if they have fractures.
We have more vertebral fractures by the chances that have, but hip fractures are really can be fatal. Not only that, patients' really lifestyle would change completely after. If they survive a hip fracture, even their dependency, they will lose it, their lifestyle, and subsequently some psychological things.
And what about the pharmacological
pharmacological, we always, I mean, that's the standard of care, calcium and vitamin D. And let me point on a very important thing about the calcium. We are always encouraging our patient to take calcium. And calcium is determined by the age and the sex of the patient. Most of the osteoporotic patients above the age of 50, women, we would advise 1,200 milligram of calcium. The easiest thing for a doctor is to prescribe 2 tablets of calcium supplement, but that's usually not the safest they will do. Recent evidence has shown that calcium supplements are related to increased cardiovascular risk. So patients you put just empirically on calcium, probably you are endangering their kidneys because also there is a 17% chance of renal stones, and you are putting their hearts into problems in the future. What you need to do is to take a proper dietary history and also advise the patient to increase their calcium from the food itself. And that's why we came up with something, I forgot to bring it this time. It's a calcium dietary guide, which shows each food item how much of calcium it contains. And the patient can calculate their calcium for a day. And the very second important message is not to exceed 1,400, because that's again been linked to problems in the heart. So each osteoporotic woman above the age of 50 or men above the age of 70 should take 1,200 based mainly on the diet and not to exceed the 1,400 milligram. That's regarding the calcium. How about the vitamin D? It's really important. And I don't believe anybody can get it in the natural way. Because you need to expose 40% of your body during midday, and most of us are indoors, either in their offices or in the schools, the children. So probably supplement, and also dermatologists are warning against skin cancer and other problems with overexposure to sun. So I believe supplements plays a major role in this, and we have number of supplements for vitamin D. The important message is to get the vitamin D level to above 75 nanomole per liter by any method, injections, anything, syrup, nasal spray. Now there is a new mode of delivering the vitamin D, or capsule. All are available, but we need to bring the vitamin D level to a normal and a safe range.
So that's the first treatment.
That is, I would say, the cornerstone. It's the basis of the treatment. Right. Without this, any medicine you will give probably will hurt the bone rather than you get the benefits.
So how do you fix then osteoporosis with regard to the other medications?
We have many drugs actually, and simply we divide them into, like you know, the bone is dynamic. Every day there are cells that comes to the bone, eat out some part of the bone, and later some cells come and build up the bones. So we have drugs acting on these bone eaters, and we have drugs working on the bone forming cells. And there are many. There are tablets, there are injections, there are injections given subcutaneous under the skin, there are injections given in the vein. So I think you need to see an expert doctor to tailor for you the proper treatment, because there are conditions in which some drugs cannot be used. In fact, it's not that complicated, but to get things easy, we have come up with this table, and we are supplying it to all the doctors who are running the osteoporosis clinic. Just a reminder of that. These are the drugs.
Yes, can we show the table,
please? If you can get closer to the drugs available.
Yeah.
Probably not. Okay, so it just shows the drugs, when not to use, when to use, and what is their effect. And it's just a reminder for all doctors in their clinic to,
which is very handy
to tailor.
For all doctors.
So it's both the guidelines and this can be kept in all the
Will be very beneficial for primary care doctors to
absolutely,
have
but things keep changing, so we cannot stick to one. Like this one, it has to be updated before we. So it has to be updated because things come up.
Okay.
You mentioned, doctor, about, of course, vitamin D, which is a very, very big issue in Kuwait, and a lot of people are aware of vitamin D deficiency. So what is it exactly?
What is it exactly? Vitamin D is a vitamin we get when we expose our skin to the sun. So if we expose the skin enough to the sun, there are the ultraviolet beta waves that penetrate to the skin, act with the 7-dehydroxycholesterol under the skin, and form the vitamin D, which is stored in the fat cells. If we need it, then it will go to the liver in the first place. It gets activated. This is the activation step number 1. Then it goes to the kidney to get activated, step number 2. And then you can get the active vitamin D that is responsible for the calcium absorption, etc. If you don't have much of vitamin D, then your body will not be able to absorb calcium. However, the body needs to have the serum calcium in a normal level. So what it will do, it will go and find where is the calcium loaded in the body, where is the bank? It's the bone. So it will send a hormone called the parathyroid hormone to go and eat up the bones to release the calcium to the circulation. If you have high parathyroid hormone, then you are at higher risk. And then you can stop this circle by giving enough vitamin D and by asking the patient to take enough of calcium. So that is the role. Not only this, that is regarding the bone, but also the vitamin D, which we call 25-OH vitamin D, which is after the first step of activation from the liver. It has receptors on all the cells of the body, from brain to blood vessels to the heart to whatever. So it goes to these cells and it acts locally in these cells to bring up some beneficial effect within this system or within these cells. And I believe you need 10 shows to talk about vitamin D.
We'll never finish if you talk about that.
You've been linked like vitamin D deficiencies to osteoporosis, but could it be linked to other diseases as well?
Vitamin D? Oh yeah, many. Like I told you, one.
Could it be linked to rheumatoid or
anything you think of? Psychological, preeclampsia in women, a lot of diseases, cancer. cardiovascular diseases, and I wouldn't, all of them, immunity.
Yeah, it's, for example, immunological diseases. Is it related to, for example, people who get sick really quickly, or is it related to people who are...
Yeah, in one of the studies they advise if you get the flu in the early stage, you can take 2,000 per kilogram vitamin D.
Yeah.
So if you are 50, you'll take how much? 50, 100,000 units of vitamin D for 3 consecutive days, and the flu would be healed.
Does it reduce the days?
It does. It does. The severity and the duration of the flu.
And what about multiple sclerosis?
Many diseases, though many doctors in the field of multiple sclerosis would not believe it. Probably does not have this therapeutic effect. So if the patient has multiple sclerosis and you treat with vitamin D, I mean, might not benefit much, but it's been linked epidemiologically. Okay, those who are vitamin D deficient have more chances of getting multiple sclerosis.
So
and multiple sclerosis is also more prevalent in areas where there is little sunshine there. And there are a lot of evidence based on this, but I think, again, it's a very broad subject that we need days to talk about.
Okay. Doctor, can you tell us what are the symptoms or what the patient could complain of when they have the vitamin D deficiencies?
Vitamin D deficiency is different from osteoporosis in that it will give you bone pain.
Okay.
Okay. So with vitamin D deficiency, there is bone pain, and the symptoms depend on the age. Like in children, it will result in some skeletal deformities, bossing of the forehead, bowing of the legs, etc.
Yeah.
In adults, it's just myalgias, unspecific muscle pains, unspecific bone pains, weakness in their muscles, some psychological feelings, and disturbed sleep. Most of these symptoms, the patient might consider this is the natural thing, but only when you treat them, then they see that these things has improved. Particularly the myalgias, many of them, all the body aches and the muscle aches disappear completely.
And how would you diagnose like vitamin D deficiency?
It's really simple, by blood test.
Simple blood test?
Yeah.
Requested, okay.
And we do check the 25-OH vitamin D, which is the first step of after activation.
All right.
Because that determines the stores.
Yeah, there was a big issue, I think, in the late few years, and it was about the machine which tests for vitamin D, and they said that it is actually not giving the right results.
Well, let me tell you something. I mean, logically, when you see the situation, most of the people are not properly exposed to the sun. So I won't be surprised to find somebody is vitamin D deficient. That's number one. Number two, if I don't believe the machine that there is a vitamin D deficiency, because when we at Amiri Hospital started this campaign of vitamin D awareness campaign, we wanted to prove there is a real problem. So what we did check the calcium, the vitamin D, and the parathyroid hormone. And in 30% of the normal population, the parathyroid was increased, which reflects a low vitamin D. So why would 1/3 of the population have high BTH and putting their bones into danger? And now I see a lot of my patients having normal vitamin D after we replenish for them. So I don't think it's an SA problem only. It's really an existing problem that probably we overcome it by 80 or 70%. I think the awareness of vitamin D is quite impressive now.
Yeah. And what is the method, or what can we do in order to treat vitamin D deficiencies? What is the options available?
Well, it's really simple. Number one, you have to see if this patient having deficiency of vitamin D, and then you have to bring them to a level of 75 nanomole. This we call a loading dose of our loading stage of the treatment. So we can either use injections, you can either use the capsule. We have other varieties. We have to do counsel with the patient and see what's more convenient for them. But however, some cases we have to give injections, like patients with malabsorption, non-reliable patients who will not take. So, I mean, sometimes we have to give injections.
Exactly, which is sometimes it's easier for the patients.
Yeah, and it's easier for the patient and come and tell you, I hear the injections are bad for the kidney. And you heard from where? Nowhere. And I reviewed the literature and I frequently do so, and I did not find any literature saying that vitamin D injection has any bad effect on the. But I would also warn that when I'm talking about vitamin D, I'm talking about the native vitamin D, that's vitamin D3. The 1-alpha that everybody is using, particularly from Al-Razi Hospital, Orthopedic Hospital, is really a crime.
It is,
because this is the active hormone of vitamin D, and I only need to give it in 2 situations. Either the patient have renal failure, and they cannot activate the vitamin D, or they have a parathyroid hormone problem, a deficiency of the parathyroid, either congenital, they are born with this problem, or they had a thyroid surgery and by accident the doctors removed their parathyroid. Besides these two conditions, there is no chance that the patient should have a 1-alpha. It's a crime, I would say.
It's endless if we talk about vitamin D, but I mean, it's a very interesting topic. Absolutely, and I hope we have another episode just completely about it. But we have a lot of questions from our audience to you today.
Okay,
and
so we'll have a report on the questions, please, if you don't mind.
First, I want to ask, what is the main issues, you know, to diagnose an osteoporosis patient?
I want to ask him to explain to all of the people how to prevent himself from osteoporosis.
Is there any risk for chronic treatment for osteoporosis that can lead to cancer or any side effect that affects the patient's life for long term?
I'd just like to ask the doctor, is there any way, the simplest way of treating osteoporosis? Is there any medication or any way of treatment that can be taken just once or twice for just that covers a long period of time? I mean, the simplest way of treating osteoporosis. That's all I want to know.
Welcome back. With regarding to the question, doctors, most of the question we answered them during our talk, but there are two questions. One question is about the treatment with the chemotherapy and patient on the cancers. Would it be prone to osteoporosis?
I understood that he is worried if the osteoporosis treatment results in cancer. So let us answer two ways. Yes, cancer and cytotoxic drugs used to treat cancer, they are having a negative impact on the osteoporosis. So that makes the patient more prone to get osteoporosis and fracture. And usually they are being treated beside this, and they usually as a routine they looked into their osteoporosis risk. So cancer and cytotoxic drugs can increase the chance of osteoporosis. I understood that he's asking if the anti-osteoporotic treatment results in cancer. There is no evidence, so it's only, I think, one injection we are using, and it is probably one of the best treatment we use it for severe cases, and we do give it for a limited time, which is 18 to 24 months, and within this period it is really absolutely safe to treat. Only with prolonged therapy it resulted in cancer in rats, and we are far beyond this, and it's quite safe. We are using it with a limited time with very good results.
That's very good. Yeah. And there's one other question also. They were asking, is there any long-term therapy for osteoporosis rather than taking the medication regularly, like every week or every day?
I mean, if I would review the way of giving the anti-osteoporotic drugs, we have a tablet that's taken every week. We have a tablet that's taken, it's not a tablet, it's a powder sachet with water every day. We have injections given every year. We have injections in the vein. We have injections under the skin given every 6 months. We have injections given under the skin every day. So, but we don't look into this factor only. We look into the whole story. What's the stage of osteoporosis? What are the complications? What are the other medical diseases the patient has? So it's not only how comfortable or how convenient for the patient to take it once a year. We look into other factors and then decide. Like this one injection every year probably is the best for the patient who had a hip fracture. Because studies has shown if you give it soon after the hip fracture, it will prevent mortality and morbidity and further fractures to occur. So we always, our practice is based on evidence-based medicine. If we have a study to recommend a drug in a certain situation, we'll go ahead and do it. But we'll not give us once a year injection just for the patient discretion or relax to have. No, it all depends on what the situation dictates us to.
There is also another question from the audience, and this is very actually questions to clarify. There's one lady says that what is the difference between osteoporosis and osteoarthritis? I think I get this lot of misconception actually in primary
and
care
osteomalacia
setting.
if you will add to this. Fine. These are three terminologies used in medicine. Osteomalacia is a bone that has no minerals in it, and that results in a vitamin D deficiency. It's a bone that has been associated with pain, and the easiest way to diagnose it is when you press over the sternum, you have pain. Then this is osteomalacia related to vitamin D deficiency. Osteoporosis, we said it's a silent disease. It's a problem within the structure of the bone. Osteoarthritis, on the other hand, would not come to us as endocrinologists. It will go either to the rheumatologist or to the orthopedic doctor, because it's a problem with the cartilage between the bones. So most of the people will have it in the knees, for example. It's the cartilage that softens the movement between the bones. It gets hardened or gets eaten up or something. So this is the osteoarthritis. It can also occur in any place where you have, like in the spine. You can have pain related to this osteoarthritis. So simply if the patient comes and tell me I have a back pain and so on, I would not consider osteoporosis in the first place. I would consider these problems or some compression on the nerves, etc. Unless this patient has features of vertebral fracture due to osteoporosis. So osteoarthritis is a problem within the cartilage between the bones.
Okay, there is also one other question coming from Saudi Arabia, and it's quite a little bit away from our topics, but because you are a consultant in endocrinology, he says, like, what are the major causes of thyroid abnormalities, and how can we prevent it? This is quite
well,
broad.
That is very broad topic.
Like,
I mean,
is there any prevention?
I always say thyroid, we look at it from two angles, absolutely two different angles. The anatomy, how the thyroid, is it big? Is it shrinking? Is it having a nodule? So this is a different aspect. And the other aspect would be the function. Is the thyroid secreting enough hormone? Is it underactive? Is it overactive? So, and there is no clear link between the two. So we'll have to analyze this separate and this is separate. So I don't know what this question is too broad.
It's too broad actually, but is there any prevention
it all depends
measure?
On, but each thyroid needs to be assessed, both aspects. The anatomy of it and the function of it before we can say it is normal.
Okay. And Dr. Nadia, just before we finish our show, what is your view or what is your insight about osteoporosis? Do you see any futures about managing osteoporosis in our communities?
I mean, we're talking about osteoporosis, a disease that is only born in 1993. It's the time when it was diagnosed or not identified, I say, or I mean, a definition was given to the osteoporosis. So it's not really an old disease. It is an old, it's mentioned in the Quran, etc. But as a disease, we started to know more about the osteoporosis starting from the definition in 1993. And since then, there has been a lot of development, a lot of drugs, a lot of research on that. Unfortunately, they anticipate that if in 2005, there used to be 2 million fractures related to osteoporosis. In 2025, there will be 3 million. And that's not related to that we are underdiagnosing osteoporosis or undertreating, or it's the population is getting age. I mean, the longevity of people, they are living longer. And once you look, and this is a disease mainly of old age. So if you have to live older, then the problems with old age comes up. And osteoporosis is no exception. So osteoporosis is a disease which I feel is the awareness about it is more among doctors. It's more among the patients. Unfortunately, we are still getting it late after the first fracture and would like to prevent it. Probably that's why we started, and you, Dr. ANOUD, you were there, to get it to the first defense line, I believe, is the primary health physicians. So if the primary health physician will focus on osteoporosis, will screen patients who need to be screened, will prevent the first fracture, I think we will succeed in that.
We will save a lot of lives and improve the quality of life.
So that's what we call primary prevention, is finding the case, treating before the first fracture. I hope we can also implement another program in the orthopedic hospital called the secondary prevention, so that each patient after they fracture, and there is a risk of osteoporosis, that this patient before leaving the hospital should be assessed if they have osteoporosis, should have the appropriate blood test, and should be directed into how to receive treatment, either by the primary health physician or by the endocrinologist or by any patients in the field.
So we will advocate for having a
primary. Now we've started the primary prevention. I hope it works. And I would advocate, it's not in my hand, it's in the orthopedic hospital, the secondary prevention.
And another thing is the continuation of educating patients with osteoporosis, and also the...
That is part of it, that's why I'm here today.
And the thing is with the thing is that I think it's missing in Kuwait, which is the, you know, the social worker part. in patients with osteoporosis, especially elderly patients who have as you said, they have unsuitable homes, or someone who has a lot of stairs and slippery floors.
Exactly. Rehabilitation for the osteoporotic. That would probably come after they have the first fracture. When their mobility probably is too late. We want to have. We've always advised our osteoporosis into how to run in a safe environment, what to do, and sometimes it's simple maneuver they do. Like sometimes if the stairs, if they just fix bars to the stairs, so that if they are climbing down or up, they have to hold on to the bars, that will prevent a lot of falls and fractures.
But do we have this kind of service, like in hospitals? Do they
Absolutely.
provide someone who goes to the homes?
I would say the outdoor service, we teach the patient how to take the injections, for example, if we prescribe for them this daily injections, but that's only for severe cases. We do have home visits and then tell them how to use it. We really have a health educator and that aspect only. And we have a lot of brochures to give out to our patients. We always advise regarding the calcium. I mean, we try to help as much as we can. I think we have succeeded, probably not completely, but
but it's amazing how far you got. It's
I hope with the also implementation of this primary prevention program, we'll do even better, inshallah.
Inshallah, yes.
Dr. Nadia, we're so thankful for this lovely information and your ambition actually to increase the awareness about osteoporosis and vitamin deficiencies. And we're so happy to have you here in our shows, to be honest. Do you have any other final talk you would like to say?
Well, I always say, let's not make the osteoporosis beat us.
All right.
We can beat osteoporosis, and this starts even pre-conception. All ladies planning to get pregnant should have proper diet. They have replenishing their vitamin D, because bones start in the womb with the mother. So if we start with this early stage, I guess we can beat the osteoporosis.
Thank you so much, Doctor. Thanks, it was a pleasure meeting you today. And that's it for our show. Thank you so much for watching us, and we'll see you next week.
Thanks again for watching us, and we'll see you also next week, hopefully. Thanks.